Okay, here we go. Welcome to the neurology unit. This neurology unit is going to have 2 narrated PowerPoint files, a lot of material to cover, and unfortunately we're only scratching the surface of neurology, but I think we got a good amount of stuff we'll be talking about. 4 chapters in the textbook devoted to neurology, and there is a file on Blackboard which shows you some select figures and tables that you should look at. No expectation of reading all 4 chapters. And you also have 1 additional week to get neurology done. So you've got 2 weeks to get through this. You've got 5 discussion threads that I want you to do. And there are 2 quizzes. And you get to use references for those 2 quizzes. Okay? So here we go. Like I said, an overwhelming amount of neuropathology that we can discuss. Going to be impossible to cover all of it. We will look at some highlights and some high points and emphasize a lot of anatomy. One of the quizzes that you will be taking will be on neuroanatomy, but again, you get to use your references. And you know me, I love pharmacology, so we'll look at some neuropharmacology as well as we go through this topic. So the central nervous system is the brain and the spinal cord, and we will be looking at the brain and spinal cord both in cadaver sections, in CT and MRI scans, as well as some other types of medical imaging. And we'll also use some graphics to highlight some points as well. On most of these slides, I will have arrows pointing to specific regions that I want you to take a look at. So in the middle there, you can see an MRI of the spinal cord being pointed out by the red arrow. And then you can see a couple of different views of the brain. And at the yellow arrow over to the left, you can see some nerves which are exiting the brainstem. Those are cranial nerves. So brainstem, spinal cord, cranial nerves, we're talking about the central nervous system. Once those nerves leave the brain, or once those nerves leave the spinal cord, then those nerves become part of the peripheral nervous system. So you're sending messages from the brain out to the body, and the body is sending messages in to the brain and spinal cord. Those messages are being carried on nerves of the peripheral nervous system, and the majority of those nerves have specific names to them. Don't worry about that right now. We'll highlight some names of some of these specific cranial and peripheral nerves as we move through the unit. When we look at CT scans and MRIs, depending on what type of image you're getting or what type of cut you're getting, you may or may not see all these various structures, particularly the lobes of the cerebral cortex. So the top of the brain, called the cerebral cortex, is divided into 2 hemispheres, and within each hemisphere are 4 lobes: the frontal lobe, parietal lobe, temporal lobe, and occipital lobe. And you can see what each of those lobes are responsible for in terms of function. Below the brain, we have the brain stem, 3 regions of the brain stem: medulla, pons, and midbrain. The midbrain is kind of buried, so in these photos here, you don't see the midbrain. It's kind of deeper, tucked in and hidden. We'll see that as we look at some different slices or different photos. And then underneath the cerebral cortex and behind the brainstem, we have the cerebellum, and the cerebellum is all about motor coordination. So it'll be important for you to be able to recognize these 8 structures, and not only recognize the 8 structures, but know what they are responsible for in terms of physiology. Here is the brain cut in half, so cut in sagittal section. Now if you look at the brainstem going from the top down, you can see the midbrain, the pons, and the medulla oblongata. So the medulla is the lowest section of the brainstem, and that's going to fuse, articulate with the spinal cord. You can see the cerebellum below the cerebral cortex and behind the brain. You can see the frontal parietal occipital lobe, and on the back side of this slice, you can see the temporal lobe. So remember, the temporal lobe is out laterally on each side of the brain. Couple other structures that are important that we'll talk about: the thalamus above the midbrain, the corpus callosum, a series of interconnecting neurons connecting the right and the left hemisphere, the hypothalamus. Remember, we talked about the hypothalamus already in the endocrine section, and then remember that the hypothalamus articulates and sends hormone to the pituitary gland, and we will review a little bit more on the pituitary gland and cover again some of that endocrine pathology related to pituitary tumors. Here is the spinal cord cut in cross section, or another term for that would be axial section. The spinal cord lives within the spinal column surrounded by the vertebral column. So the vertebral column makes up the spine, and centrally within the spine is a hollow spinal column, and in there is the spinal cord. The spinal cord has a sensory part and a motor part. A nerve leaves the sensory part. A nerve leaves the motor part. They join together out in the periphery to become a peripheral nerve. So that peripheral nerve contains both sensory and motor components. And in some areas of the spinal cord, that nerve will also contain components of the autonomic nervous system. And as you remember, we talked about the autonomic nervous system a bit in lungs and heart. We'll come back and review a little bit more related to the autonomic nervous system in this unit as well. Neurons are the only cells of the body which can produce and conduct electrical impulses. You can stimulate or inhibit neurons. Neurons can transfer and store data. Neurons create those electrical impulses which allow us to think, have motor actions, perceive sensation, feel sensation. Neurons are not the only cells of the central nervous system. Another type of cell in the central nervous system are the glial cells, and the glial cells I kind of think of as being support cells to the neurons. Glial cells have a number of different functions in the central nervous system, but they do not create or conduct electrical impulses. Those are only done by the neurons. The neurons are much larger cells, glials are much smaller, but the glial cells outnumber the neurons by about a factor of 10 to 100 times. So about 110 billion plus neurons and 100 plus billion glial cells. So many cells within the central nervous system, brain and spinal cord. And the two primary types are subdivided as neurons and glial cells. Here's some diagrams of neurons. Neurons, like any type of cell, are capable of metabolism. They have all the usual components of any other cell, including things like mitochondria, nucleus, chromosomes, DNA, enzymes, cell membranes. But their shape is a little bit different. Take a look. They have a central cell body, In that cell body are going to be the nucleus and all those organelles like mitochondria, cytoplasmic reticulum. They have an input region referred to as the dendrites. They have a transfer axon, one large axon per each neuron, which transmits the electrical message from input to output section. And then they have an output region referred to as the terminals. Only in the axon you will find wrappings of myelin. And myelin is a special protective fatty insulating coating of the axon, which allows the electrical message to move quicker in a more efficient way from input to output. So from dendrite to terminal output region. Think of the dendrites as picking up the stimulus, the axon carrying the stimulus, and then the stimulus arriving at the output region. The stimulus is converted into an electrical message right at the cell body. If you look in that lower left picture, do you see the cell body, and right underneath it you see something called an initial segment. That segment of the neuron is where the electrical impulse gets manifested, and then you can see it'll travel down the axon to the terminal output region. There are many dendrites on a neuron, many axon terminals on a neuron, but only one cell body and one axon. And only on the axon do you find the myelin. And here you can see a differentiation of gray matter versus white matter in the brain and in the spinal cord. White matter, the area of white matter is myelinated axons, and the areas of gray matter are primarily the cell bodies and dendrites of the neuron. If you look at the brain, you see the gray matter tends to be out laterally and the white matter centrally, although you can see deep central in the brain, many areas of gray matter. Can you see that? And then if you look at the spinal cord, you see that the gray matter is primarily central and the white matter is out laterally. A little bit more difficult to see in the MRI of the spinal cord. The spinal cord is fairly small in thickness, only about 6 to 12 millimeters, so you have to do some type of enhanced magnification to be able to really differentiate well that gray versus white matter on the MRI. See where the spinal cord sits in that spinal column designated by the yellow arrow. And what's that white matter all about? That white matter is all about myelinated axons. Those myelinated axons are delivering the electrical message from one site of the central nervous system to the other. The electrical activity is referred to as an action potential. We'll cover that in a little bit here. Let's focus on the myelin. The myelin surrounds the axons, and myelin is surrounded by special types of glial cells. I'll name them oligodendrocytes and Schwann cells. Are two types of glial cells which make myelin. And that myelin wraps around the neuron almost like a, when you peel an onion, how you got the different layers of the onion. Take a look in that smaller photo, almost right in the center, and you can see the layers of that myelin on a high-powered microscopy surrounding the axon. And you can see in the picture next to it on the left, you can get a vision, you can get an idea as well. See that oligodendrocyte there creating that myelin sheath, which is wrapping around the axon. Look at the MRI sections in coronal section on the right and sagittal section on the left, and you can easily see the differentiation of gray and white matter. And then again, in a brain biopsy, right above the MRIs, you see a number of neuron axons. All those circular structures that you're looking at are neuron axons, and you can see that those are all surrounded by a white material. That white material is the myelin. And the role of myelin is to insulate those axons to deliver the electronic message, the action potential, more efficiently and quickly. And that is referred to as salutatory conduction. An axon which is myelinated, the information travels quicker. That's referred to as salutatory conduction. Not all axons have myelin. We do have some unmyelinated axons, and that information travels a bit slower. We'll make a couple points about that. So let's keep talking about myelin for a second here, and let's talk about tracts. Another term that's used is fascicles. But tracts are numbers of axons getting together and sending a message from one part of the central nervous system to another part of the central nervous system. Think of the tract as kind of like a dedicated road going from point A to point B. And that's all made up of white matter axons. So if you look down at the left photo, you can see that we're starting in the brainstem, and we want to send a message into the frontal, parietal, and occipital lobe. That message is being carried on numbers of axons carrying the same message. So they're all doing the same thing, so we refer to that as a tract. And that tract would be a single source divergent tract, meaning it's starting at one site but going to many sites. You can see that in the black. So that black is highlighting a specific tract in the brain. And then in the spinal cord, now look here, we're starting a message up in the brainstem. We're starting it at a part of the brainstem referred to as the red nucleus. And you see how that tract moves down the different areas of the brainstem and eventually into the spinal cord. So that is another tract. That would be an example of a point-to-point, single source, one destination tract. And we're going to talk more about these tracts as we move on and get into some of the pathology. Gray matter versus white matter on imaging studies, be careful, because sometimes the pattern is reversed, particularly when you're looking at the brain with contrast or different types of settings or diffusion images which are set on the CT scans or on the MRIs. But in general, on a CT scan, the white matter will appear grayer and the gray matter will appear more dark. So you can see the differentiation of gray matter and white matter on those CT scans. Air and fluid will look black. So in the blacker regions of those CT scans, that's actually cerebral spinal fluid. And you can see the hollow ventricles in the center of that CT scan. In the ventricles is fluid, so that's why it looks blacker, okay? Now look at the MRI. The MRIs at the bottom, those are much more detailed images, and it's a lot easier for you to differentiate the gray matter versus the white matter. On the left photo, the white matter looks more grayish, the gray matter looks more darker, and again, the fluid in the ventricles appears black. Now look at the image on the right, and that diffusion has been reversed and there's contrast in there. Now you see the fluid, the cerebral spinal fluid, taking on that bright white photo, white appearance. You can see the gray matter looking darker, and you can see the white matter looking a little lighter, looking more gray. So there are some diseases which exclusively affect white matter. Right now, before we get into any of it, I'm sure some of you know, can you name a disease which only affects the white matter, meaning it's only affecting the axons? Did you get one? How about multiple sclerosis? That would be a good example of a disease that only affects the white matter. Now, let me tell you something that I don't know anything about medical physics or how these machines work, so don't ever ask me a question on how the image got generated. I have no idea how the image got generated, but I can do fairly well at looking at an image and tell you what we're looking at. I just don't know how it got there in the first place. But that's all right, because most clinicians are not medical physicists either. All right, on we go. All right, let's do our first rule of neuroanatomy. The brain is inside the skull and sits on the base of the skull. So here we have a cadaver, and we're going to take away skin, muscle, and connective tissue. We're going to take away the bone. We're going to take away the outer dura, the outer meninge, and then we're going to see the brain there inside the skull. Right? So first rule of neuroanatomy, the brain is inside the skull. Second rule, the brain sits on the base of the skull. So let's do the same thing again. Take away the skin, connective tissue, bone, dura mater. We can see the brain, and then as we start removing the brain out of the skull, we can see the base of the skull. So the brain is inside and on the base of the skull. There are some indentations, if you will, on the base of the skull referred to as fossa, and certain parts of the brain rest on those fossa. So at going front to back, anterior, posterior, 1 being anterior, 3 being posterior, we have the frontal lobe fossa where the frontal lobes sit, the temporal lobe fossa where the temporal lobes sit. Remember, the temporal lobes are out laterally, the frontal lobes are out in front. Now be careful, at number 3, it's not the occipital lobe, it's the cerebellum. And it's not the occipital lobe because remember the cerebellum is underneath the occipital lobe. So if the brain's going to sit on the base of the skull, in the most posterior fossa is the cerebellum, the 2 lobes of the cerebellum. And then you see the big hole in front of that posterior fossa. That large hole is where the brainstem is going to articulate with the spinal cord. So more on that as we move on. The brain and the spinal fluid the brain and the spinal cord are hollow in the central regions, and that's full of fluid, cerebrospinal fluid. The brain and the spinal cord are completely surrounded by 3 coverings, meninges. So going from outer to inner, the meninges are the dura, the subarachnoid, and the pia mater. So on the cadaver photo, you can see the dura mater has been cut and split, and then you can see the probe underneath the arachnoid membrane. The pia mater is tightly adhered to the brain, so it's tough to take the pia mater off. And then in between the subarachnoid and the pia mater is a space referred to as the subarachnoid space, and we find CSF in there as well. So CSF is in the center of the brain and spinal cord, and it also surrounds the brain and the spinal cord. And the CSF surrounding the brain and the spinal cord is located in the subarachnoid space. You can see all the CSF surrounding the brain and spinal cord in the middle picture. And then on the right is a graphic of what the ventricles, if you were to isolate the ventricles, take the brain away and just leave the ventricles, you can see what the ventricles look like, and they span through the frontal, parietal, occipital, and temporal lobes. Okay, the brain is in the skull and sits on the base of the skull. To get things in and out of the brain, then, you need holes in the skull. Those holes are referred to foramen. So through those holes, we will have arteries and veins exiting. We will also have cranial nerves exiting the brain. But we also have one large hole at the base of the skull, and that's referred to as the foramen magnum. The foramen magnum is the only foramen, or the only hole, that I want you to know by name. And that is where the spinal cord comes. So now look at the brain flipped inverted on the lower left picture, and you can see the cerebellum, you can see the temporal lobes, and you can see the frontal lobes, and you can see the spinal, you can see the brainstem, and now imagine the spinal cord extending off the brainstem. Now you got to think in 3D here, pick up that brain, invert it, and place it on the base of the skull, right? Like you're doing a puzzle, and you can see those frontal lobes go anterior, temporal lobes go in the center, and the cerebellum goes in the posterior fossa, and then that brainstem spinal cord going to go right through the foramen magnum. And like previously stated, the skull has many foramen for blood vessels and cranial nerves to enter and exit. You can see all the different fossa there on the human skull. And lucky for you, we're not going to go through every single one and name every one and understand what's going through each of those. That would be a task. But we don't need to do that. But we do want to know what is the name of the hole right there designated in the yellow as number 6. That's the foramen magnum, and that is for the spinal cord to come up to the brainstem. All right, so the brain sits in the skull, on top of the skull, and it's all happy and well until something happens inside the skull that increases the amount of volume or pressure in the skull. So the brain's in a closed space, right? And there's a lot of volume in there, right? You've got brain tissue, you've got arterial blood, you've got venous blood, you've got cerebral spinal fluid, you have the meninges. So all that volume causes pressure inside the skull, and we refer to that as intracranial pressure. Now, what do you think can happen if the pressure builds up inside the skull? That's going to be devastating to the brain, right? The pressure is not going to build up so much that the skull is going to explode, right? If you take take a bottle of Coca-Cola, have you ever done this? Take a bottle of Coca-Cola and you drop a bunch of Mentos in it and you cap it, right? And then all of a sudden that pressure builds up and builds up and builds up and expands the bottle, and maybe you could blow the bottle up. Well, that can't happen in the brain. You can keep adding more and more pressure in there, but the skull's not going to blow up. What's going to happen is the brain is going to shift, and we call that herniation, and that can be devastating. So the first thing we're going to talk about with respect to pathology is elevation of intracranial pressure. How does that happen? Something develops inside the brain that leads to expanding volume. And we'll refer to that as a space-occupying lesion. A space-occupying lesion can be anything that takes up space inside the skull. It could be blood, it could be a tumor, it could be an abscess, it could be an excessive collection of cerebral spinal fluid, it could be a cyst, whatever. If it's inside the skull and it's taking up additional volume, that increase in volume is going to increase the pressure. And elevated intracranial pressure can lead to shifting and movement of the brain, and that movement of the brain is referred to as herniation. You can see that the brain can herniate lateral to medial, medial to lateral, superior to inferior, and inferior to superior, top up, bottom down. 6 different ways the brain can herniate due to space-occupying lesions which elevate intracranial pressure. And as you can imagine, that can have devastating and even lethal consequences. So if you look at the bottom, going from left to right, hydrocephalus, excessive accumulation of cerebral spinal fluid, metastatic tumors, AV malformations and aneurysms, outpouching of blood vessels with increased amount of blood, and then trauma such as an epidural hematoma. Again, these would all be considered to be space-occupying lesions, increasing the volume and thus increasing the intracranial pressure. So in this graphic here, we're showing a tumor growing in the central region of the brain, and as that tumor in green starts to grow, pressure builds up, and you can see the different ways that that brain can be pushed, or different anatomic ways that there can be cerebral herniation. And remember, any way can be lethal, particularly if the brain herniates down. Look at number 2 here. If the brain starts to herniate downward, one thing that can happen is the cerebellum starts to impinge on the brainstem, and the cerebellum starts to push downward the brainstem and itself, the cerebellum, into the foramen magnum. And as the brainstem controls vital functions such as heart rate, blood pressure, and respiratory rate, you can see why that can be lethal. In fact, many people who die of brain lesions due to space-occupying lesions like tumors, epidural hematomas, etc., is due to that downward herniation that has its lethal effect on the brainstem. Here's some examples of more space-occupying lesions: a brain tumor, increased cerebral spinal fluid, a hematoma, brain abscesses, a large aneurysm. They're all different. They all expand at different rates, and the rate of expansion and the height of intracranial elevation therefore determines how symptomatic the individual becomes, how much herniation occurs, and whether or not that can be potentially lethal. So at the beginning, when a space-occupying lesion starts to develop, an individual may not even be aware of it or may only have mild symptoms. But as that lesion expands and the brain begins to herniate, the symptoms become more devastating and eventually lethal. So here's a coronal sections of a brain. So we're looking in a coronal section and we're looking towards the back of the brain. Let's look at the left image here. You can see the parietal lobe at top, the temporal lobes. Out laterally, you can see the brainstem going through the foramen magnum. And on each side of the brainstem, you can see the cerebellum. Now move over to the right, and you see the big tumor in the left cerebellum. As that tumor grows, intracranial pressure expands, and eventually there will be displacement, downward herniation and displacement into the foramen magnum. So look at the 2 photos really closely at the cerebellum, the brainstem, and the foramen magnum, and you can see the difference now between the unaffected normal image on the left and the image with the tumor on the right. You should be able to see both lateral to medial herniation of the brain, and you should also be able to see some downward herniation of the brain. And the other thing happening in that right photo is as that tumor grows, that tumor starts to impinge on cerebral spinal fluid flow. So the other pathologic finding that you see going on is hydrocephalus. Remember, the ventricles full of cerebral spinal fluid are going to look black. So you see how those ventricles are increasing in size in the individual with the cerebellar tumor. All right, so that's a really nice photo showing you a mass lesion and showing you consequences of a mass lesion, including 2 different ways of herniation and accumulating hydrocephalus, accumulating cerebral spinal fluid. Okay, we measure intracranial pressure in millimeters of mercury in the same way that we measure blood pressure in millimeters of mercury. Blood pressure, we get a systolic and a diastolic component. With respect to intracranial pressure, we just get one number. We don't get that systolic over diastolic component. Normal intracranial pressure is about 5 to 15 millimeters of mercury. Starts to be considered to be elevated once we get above 20. And the higher the intracranial pressure elevates, the more likely you are to begin seeing symptoms. So somewhere around 25 millimeters of mercury, and in some people it might be a little bit lower, but let's just use 25 for now. At about 25 millimeters of mercury of intracranial pressure, the individual starts to develop symptoms. So we're going to cover these in detail, but think for a second here, what do you think are the initial symptoms of elevated intracranial pressure? Headache, nausea, vomiting, visual changes. Hopefully you've all said that. We'll get to that in more detail. And again, the higher the pressure, the more profound is going to be the neurologic disability. And eventually that pressure will get so high that it's going to be higher than the mean arterial pressure. Remember, we talked about mean arterial pressure in cardiovascular. Mean arterial pressure is that pressure which is leading to perfusion of organs. If intracranial pressure is greater than mean arterial pressure, then you can't get blood flow up into the brain. And when there's no blood flow up into the brain, no cerebral perfusion, then we refer to that as brain death, not getting any blood flow up in the brain. You have probably all seen people with profoundly elevated intracranial pressure, and you know that it can affect pupil movement, as well as pupil dilation and constriction. So you can get dilated, fixed, unilateral or bilateral pupils due to elevated intracranial pressure. You can get impingement and impairment of extraocular movements. Person can't look up or down or can't look side to side. If you are looking in retina, you can see swelling in the retina. You get a distortion of the optic nerve referred to as papilledema. You can see individuals developing both decerebrate and decorticate posturing. And then Cushing's triad, due to lethal elevation of intracranial pressure, where the individual becomes profoundly hypertensive, bradycardic, and then starts to show apneic patterns of breathing referred to as a Shane-Stokes respiration. Rapid breathing, slow down apnea. Rapid breathing, slow down apnea. And I'm pretty sure that numbers of you have managed patients with profound elevation of intracranial pressure who manifested things like unilateral dilated pupil anisocoria, extraocular motion paralysis, papilledema, posturing, and Cushing's triad. Now, before we get to that degree of malignant intracranial pressure, often the patient starts having other signs and symptoms as the pressure starts to elevate, right? So headache, fairly classic, particularly morning headache which is worse in the morning, vomiting which is worse in the morning, visual deficits, cranial nerve findings, changes on the retina, ataxia and balance, inability to hold coordination, difficulty walking, increase in muscle tone, and then eventually, as pressure continues to elevate, signs of Cushing's triad with elevated blood pressure, low heart rate, and the Cheyne-Stokes respiration. So look at the MRI. You can see the brainstem. So let's, again, can you see all that? You can see the spinal cord. You can see the spinal cord coming up into the skull at the foramen magnum. Then you can see the medulla, the pons, and the midbrain, the three components of the brainstem. And then on top of the brainstem, see the thalamus, see the cerebellum behind the brainstem, the occipital lobe on top of the cerebellum, the frontal lobe at the front of the skull, the parietal lobe in the center. And because this is a sagittal section looking at the middle of the brain, we don't see the temporal lobe. The temporal lobe would be behind this structure, right? Got to think in 3D here. And then move over to the graphic and you can see the brainstem, medulla, pons, and midbrain, and all those cranial nerves are coming off the brainstem. Cranial nerves are responsible for sensory and motor functions of the head and neck. There's 12 of them. So in an individual with elevated intracranial pressure, particularly if there's starting to be downward displacement of that pressure, that can adversely affect cranial nerves. Same thing if the mass lesion were right on the brainstem and pushing on the brainstem, another way that those cranial nerves can be affected. So doing a good cranial nerve exam in an individual with a headache, if you find cranial nerve findings, one of the things that you got to be concerned of immediately is there's something going on which is elevating intracranial pressure. So special senses, seeing, hearing, tasting, smelling, sensation on the face, movement of the head and neck, movement of the eyes, blinking the eyes, chewing, talking, swallowing, raising your palate, right, saying ah, turning your head, facial expressions, moving your tongue, constricting your pupils. Those are all motor effects. And then gait and balance, the ability to walk a straight line, hold your balance. That comes from the cerebellum along with cranial nerve 8. So again, disturbances here, when you start seeing cranial nerve disturbances, one thing that you got to be thinking about is pathology, direct pathology of the brainstem, or elevated intracranial pressure having a downward effect on the brainstem. So what you can do here is you can take all of these motor things that are being demonstrated and then see if you can attach or match each of those to a specific cranial nerve. Use this in the slide previously. So the person saying ah, the person moving the tongue, puffing out the cheeks, pupillary constriction, facial expressions, opening the mouth, etc. You should be able to match those to select cranial nerves. And then again, in a very detailed neurologic exam, you want to be doing all those. You want to be doing all that clinical testing to specifically test for all those cranial nerve functions, particularly the motor functions. All right, now let's talk a little bit more about some specific entities which elevate intracranial pressure. And let's talk first about hydrocephalus. So look at the normal CT scan on the right where the ventricles are fairly small, and then come over to the left and you can see that marked dilation in the ventricles due to expansion of cerebrospinal fluid. So remember, cerebrospinal fluid circulates through the brain and around the brain and spinal cord, and you can interrupt that flow with obstructions anywhere. One of the critical regions where brain CSF can be interrupted is centrally in what's referred to as the third ventricle, or what's another area referred to as the aqueduct. If you have some type of pathology that compresses the third ventricle or compresses the aqueduct, then CSF can't move. And when CSF can't move, it accumulates. It accumulates above the obstruction. So now the lateral ventricles start to dilate, and that's what we see happening in the CT scan, is the dilation of those ventricles, hydrocephalus, probably due to an obstruction which is occurring more inferior in the brain. In this CT scan here, probably occurring somewhere in the region of what's called the aqueduct. So as CSF accumulates, intracranial pressure raises, and the individual starts developing those symptoms of intracranial pressure. And as CSF continues to accumulate and no interventions are done, then we can start seeing those lethal, moving into those lethal effects, such as Cushing's triad, the decerebrate posturing, and an eventual no perfusion and brain death. A couple different forms of hydrocephalus. Congenital, the infant is born with it due to some type of anatomical malformation that may manifest in utero. It may manifest shortly after birth, or it may take a little bit of time for that to manifest. So in the normal newborn screening and well child care for pediatrics, particularly in the first couple of years of life, serial measurements of head circumference, and a child whose head circumference is growing faster than their length of their body, that might be one thing we got to worry about, is the child developing hydrocephalus or ventricular swelling. Acquired hydrocephalus, again, usually due to obstructions, hemorrhage, meningitis, trauma, cyst tumors. We're going to look at all these things as we move on here. So congenital, born with it. Acquired, some type of lesion occurred in the brain which is obstructing cerebral spinal fluid flow. And one intervention that needs to happen or could happen to individuals who can't move cerebral spinal fluid around the brain is to get around the obstruction. And neurosurgeons can place what are referred to as ventricular peritoneal shunts or ventricular atrial shunts, where the VP, ventricular peritoneal shunt, is more common. A catheter is put through the skull, and the proximal catheter is placed in the ventricle, and then the catheter is attached to a reservoir and a valve, a one-way valve, and then a longer catheter is then tunneled down into the peritoneum. And now, as pressure builds up in the ventricle, as CSF accumulates, it will open up that one-way gravitational valve, then the fluid will move out of the ventricle into the peritoneal cavity, and then that fluid will reaccumulate and be reabsorbed. So a number of pictures here showing you graphically what that looks like, and then showing you some x-rays where you can actually see the proximal catheter in the ventricle going through a burr hole in the skull, and then that large catheter then being tunneled down the skin and eventually into the peritoneal cavity, where that fluid will then move from ventricle to peritoneum. The ventricular atrial shunts, I've seen a couple of those. Those are much less common than the VPS shunt. And these shunts are prone to problems. They can break, they can obstruct, and they can get infected. And when that happens, when the shunt fails, CSF will start to reaccumulate, and the individual then will start developing symptoms of elevated intracranial pressure. So here you can see an infant who just had a VP shunt in. This infant looks like he or she is post-op. You can see the surgical site. And then here's a child, older child, it looks like. VP shunt probably been in place VP shunt put in place, and then you can see the staples there putting the scalp back together. Hydrocephalus, depending on the degree of hydrocephalus, the individual may have minimal to any symptom or impairment. As the hydrocephalus expands, then obviously that can result in a numbers of different types of impairment, both motor, sensory, and cognitive. And with really severe hydrocephalus, that certainly can lead to severe disability. So again, if you have a child or teen or adult, whatever, with hydrocephalus, that does need to be corrected. And one of the more common ways of correcting that is with the installment of ventriculoperitoneal shunt. So again, they can be problematic, they can obstruct, they can infect. Shunts can obstruct with debris and protein. The proximal end of the catheter can fall out of the ventricle or push up against brain parenchyma. The catheter itself can break. So any individual with a VA or a VP shunt who starts to develop headache, change in behavior, irritability, lethargy, altered mental status, fever, vomiting, ataxia, abnormality in extraocular movements, and even incontinence. That's an interesting one, incontinence. Individuals with those symptoms suggestive of elevated intracranial pressure who have a VP shunt in place need to be initially managed and suspected for elevated intracranial pressure, meaning urgent medical imaging of the shunt and the brain to look at placement of the shunt itself, the integrity of the shunt, and whether or not there's accumulating hydrocephalus. So very important, VP shunt in place and the individual starts developing headache and vomiting, change in behavior, visual disturbances, ataxia, and a very unusual symptom, incontinence. And again, they don't have to have them all, but some combination of those symptoms in the individual with a VP shunt in place, they need medical imaging. And specifically, we're looking for integrity of the catheters in the shunt, and we're looking for whether or not the ventricles are starting to dilate with CSF, because if they're dilating, that probably implies that the shunt is not working, and then that requires emergent neurosurgical consultation. So here's one of the threads that we have in Blackboard is, have you managed any patient with a VP shunt malfunction? And you can tell us about that in one of those neurology threads. Okay, let's move on to tumors. So tumors growing inside the skull can also be examples of space-occupying lesions. Remember, a tumor can be benign or malignant. If it's malignant, it's cancer. If it's benign, it's not cancer. But again, benign does not imply not worrisome or no symptoms, because even a benign tumor growing in the brain can raise intracranial pressure. Tumors in the brain, primary tumors of the brain, are typically named by their site of origin and the type of cell from which it arose from. So as an example, a cerebellar astrocytoma is a tumor which started in astrocytes of the cerebellum. A brainstem glioma, a tumor which started in glial cells of the brainstem. A meningioma began on cells of one of the meninges. A ependymoma began on cells lining the ventricular cavities. So you can see that there's a lot of different types of primary brain tumors, but in addition, we also have metastatic tumors that can go to the brain as well. Important point, whether it's benign or malignant, all expanding lesions inside the skull can raise intracranial pressure. So here's an example of an astrocytoma. An astrocyte is a specific type of glial cell in the central nervous system. One of the roles of astrocytes is to create what's referred to as a blood-brain barrier. They wrap around blood vessels and make the blood vessels less permeable or less leaky. And if you have a tumor which begins from abnormally proliferating astrocytes, then that's going to be referred to as an astrocytoma. So if you move over to the left side, you can see a normal biopsy of a brain showing you myelinated axons and neurons and numbers of glial cells, and then a more magnified image of a astrocytoma showing you a lot of that anaplasia, loss of cell polarity, loss of cell architecture. Remember, we talked about anaplasia as being a finding of cancer. So there would be a histologic view of what anaplasia might look like within a astrocytoma. And then there in the post-mortem section, on the right side of the brain, you can see that very large, devastating, infiltrating, even hemorrhagic astrocytoma. So just by looking at these photos, can hopefully you can understand at this point that that would be a malignant tumor, right? Anaplasia and invasion. Because it started in the brain in an astrocyte, would we consider that a primary or a metastatic cancer? Right, that would be a primary cancer. And would a tumor like that raise elevated intracranial pressure? Absolutely, for numbers of different reasons, right? One, for the expansion of the tumor. Another reason might be as it hemorrhages and blood starts to accumulate in there. And another reason could be if it begins to obstruct flow of CSF. So the tumor, hemorrhage of the tumor, CSF due to obstruction of the tumor, all of those can lead to marked elevations of intracranial pressure, herniation of the brain, and eventual all those bad symptoms of lethal intracranial pressure, such as posturing, Cushing's triad, no brain perfusion. All right, so there's some nice pathologic examples of a bad astrocytoma. And then coming back, we looked at this picture already, right? We looked at this, look at that middle coronal CT scan. We looked at that already in terms of the tumor in the cerebellum. Now this is an astrocytoma in the cerebellum. And again, now you can see and understand hopefully a little bit better now why that tumor might be causing hydrocephalus. So you can, at the yellow arrow, that's the aqueduct, right? So you can see how the brain is herniating and impinging on the aqueduct. If CSF can't move through the aqueduct, see how the CSF starts to accumulate in the ventricles above it, hydrocephalus. And then at the red arrow, you can see the downward displacement of that tumor on the brainstem. And then in the postmortem section, you can see that large tumor inside the cerebellum and see how that tumor is starting to take over and invade into the cerebellum. So what might you expect in this individual in terms of early signs and symptoms before that individual develops all the devastating and lethal effects of herniation? You might expect to see signs and symptoms in that individual before it got really bad, right? So what would you think you would see in this individual? You would start to see the signs and symptoms of early elevation of intracranial pressure, right? Headache, morning headache, nausea, vomiting, morning vomiting, visual disturbances. And then you would also start to see the signs and symptoms due to the effect on the cerebellum. And the cerebellum is all about coordination. So you might start seeing individuals with impaired coordination, gait disturbances, ataxia. So let's look at the cerebellum as we move on here. We'll start talking more about the cerebellum and start talking a little bit more about the neurologic exam for cerebellum findings. So one disorder of the cerebellum can be cerebellar tumors, and those tumors are in the posterior fossa. Remember, the posterior fossa is the back of the base of the skull, and that's where the cerebellum sits. Look at that picture of the base of the skull again, and you should be able to pick out the posterior fossa. And then a number of different images, CT and MRI images up at the top, and you can see all those tumors, right? You can see all those tumors within the cerebellum. Cerebellar tumors can be benign or malignant, but whether it's benign or malignant, again, they will all elevate intracranial pressure. They can be primary, meaning they started in the cerebellum, or they can be metastatic. They started in another region of the body and metastasized to the cerebellum. Many of the primary tumors of the cerebellum come from glial cells like astrocytes. In terms of pediatrics, these are the most common solid cancers of childhood, glial tumors of the cerebellum. And you can see astrocytomas are one type, a medulloblastoma is another type. Cerebellar astrocytomas and cerebellomeduloblastomas have a fairly high incidence of metastasizing to the spinal cord. And in the second narrated PowerPoint video, we'll talk a little bit about spinal cord tumors. Tumors can cause cerebellar dysfunction, but a number of other pathologies can also primarily affect the cerebellum. Individuals can have strokes of the cerebellum, multiple sclerosis, a demyelinating pathology we'll talk more about, can affect the cerebellum. Alcohol intoxication, in fact, impacts the cerebellum. Why can't people have, you look at somebody who's drunk and they stumble and they fall, their coordination is off, and they can't do motor activity like driving, right? One of the reasons that you don't want to be drinking alcohol while you're driving is due to its motor effect on the cerebellum. So both acute and long-term chronic alcohol abuse can have devastating effects on the cerebellum. Bleeding, degenerative disorders, encephalitis, congenital malformations, a lot of different pathologies can affect the cerebellum. So be aware of that. Cerebellar dysfunction on an MRI or CT scan, right? We can maybe see the tumor or maybe see the degeneration. In these MRI images, the normal side is on the right where you see a big plump cerebellum, and then look at the atrophied cerebellum on the left. And that could be due to a number of different things, including long-term alcohol abuse. And then again, signs and symptoms of cerebellar dysfunction: abnormal gait, ataxia, abnormal coordination. Other things that you can see are nystagmus. You can have the individual do finger to nose testing, right? So have them use their index finger, touch your index finger, touch your nose, index finger, nose, back and forth, each side, right? So all those kind of rapid movements which require coordination, that's all testing the cerebellum. Think of the road test that an individual gives somebody when they're pulled over for drunk driving. Essentially what they're doing is they're testing coordination, testing function of the cerebellum. Okay, here's a patient I saw a number of years ago. This is a young female who had been seen a couple of times for headache. And what had happened is over time she started getting a progressively worsening headache. Headache started to was reported as being worse in the morning, and then she started having morning vomiting. And then some other symptoms started to develop, and she had an MRI. So here you can see an axial coronal and frontal MRI, and hopefully you can see this contrast enhanced, CT scan, this contrast enhanced CT scan with the large tumor. Now, looking at this, you should be able to start answering some questions. In which lobe is the tumor located? Is she showing signs of elevated intracranial pressure? Can you see signs of brain herniation on these scans? Do you believe this is life-threatening? And what other neurologic problems do you think she would have due to a tumor in this region of the brain? So I want you to stop, answer those questions, and then I'll give you a brief answer, okay? Check yourself, see if your answers are right. So go ahead, stop. Hi, you're back? Okay, here we go. This is in the frontal lobe, right? This is in her left frontal lobe. Does she have signs of elevated intracranial pressure? Yes, particularly that worsening headache, morning vomiting. This photo definitely shows you some lateral to medial herniation on the axial photo and some downward herniation on the coronal photo. Obviously, this is life-threatening. And what other neural problems would she have? Well, this is frontal lobe. You got to think about what's the frontal lobe responsible for. As I recall, there was significant changes in concentration abilities, mental status, personality, a lot of altered mental status and concentration type stuff was going on in this individual, in addition to the worsening headaches. Brainstem tumors are particularly lethal due to the critical structures in the brainstem which control heart, vasculature, and respiratory function. So in the brain stem, in the medulla, in the pons, in the midbrain, are collections of nerve cell bodies arranged in what's referred to as a nuclei. So this is a little bit different. The nucleus of a neuron is in the cell body where the chromosomes and the DNA are, but the term nuclei refers to a collection of cell bodies of neurons which are responsible for a certain function. So cell bodies of these cranial nerves come off nuclei, and these nuclei are gray matter regions within the midbrain. And as you look at in the center section here, so at the top is cerebellum, at the bottom below it is the pons, and you can see differentiation between white matter and gray matter in the pons, right? So all that gray matter are specific nuclei, collections of cell bodies of neurons responsible for a select function. And then you can see in red a large glioma, a large tumor now starting to occupy a part of the pons. So that would be a brainstem glioma, and now you can see as that glioma occupies and starts to devastate the brainstem, those nuclei are affected, and therefore you start to see the abnormal cranial nerve findings. And again, go back and review all that. What are the cranial nerves responsible for in terms of motor effect? So an individual with headache and cranial nerve findings, again, one of the things that you got to be worried about is brainstem pathology, such as, in this case here, an example, a glioma on the brainstem. Pituitary tumors we talked a little bit about in the endocrine section. Pituitary tumors can be secretory, such as a benign adenoma. And remember, those pituitary tumors can secrete typically one hormone of the anterior pituitary gland, such as TSH or ACTH or prolactin or growth hormone. And then you can have destructive tumors of the pituitary gland, malignant tumors of the pituitary gland. Those are typically non-secretory but destructive, and then the individual starts to lose the ability to synthesize and secrete those anterior pituitary tumors. An example of such a tumor would be a craniopharyngioma shown in the most right MRI. So another critical structure that you want to be able to identify, particularly in a sagittal MRI, is the pituitary gland. So again, whether it's benign or malignant, tumors of the pituitary can raise elevated intracranial pressure. They can lead to visual deficits. The crossover of the optic nerve, your visual nerve, occurs right in that region of the pituitary. So if a tumor is growing on the pituitary and impinging on that optic chiasm, or the crossover of the optic nerve, individuals can have a variety of visual field deficits. And again, remember, pituitary tumors can be in one of two forms. They can be adenomas, which are secretory, or they can be destructive, and then those destructive tumors minimizing synthesis and release of pituitary hormones can lead to hypopituitarism. And when multiple hormones are involved, when the individual is unable to release multiple anterior or posterior pituitary tumors, we refer to that as panhypopituitarism. Pan meaning all of it, right? Panhypopituitarism. All of the hormones are being affected. So let's talk about panhypopituitarism for a second. One cause of panhypopituitarism can be a destructive tumor, such as a craniopharyngioma. Those individuals may develop signs of elevated intracranial pressure, including headache, nausea, vomiting, and visual disturbances. And then, due to the tumor adversely affecting hormones, in that the hormone is, the tumor is destroying the pituitary gland, and now the pituitary can't synthesize and release those anterior pituitary hormones, the individual starts to develop the symptoms of panhypopituitarism due to the endocrine disturbance. Feeling fatigued, constantly drinking and constantly urinating, gaining weight, loss of a sex drive, male impotence, amenorrhea, inability to ovulate, inability to conceive a pregnancy, inability to lactate, low blood pressure, low sodium, low heart rate, continual feeling of being cold, and a lack of skeletal muscle growth and a lack of bone mineralization. These are all symptoms of panhypopituitarism. And now if you're really good and remember endocrine, what you should do is take all of those symptoms and relate those symptoms to one of those pituitary hormones. We can do this. Here, I'll give you a couple of them. The person is gaining weight and feeling cold. What do you think that's due to a lack of? I hope you tied that to thyroid, right, and TSH. How about peeing all the time, drinking all the time and peeing all the time? How about ADH, arginine vasopressin, antidiuretic hormone from the pituitary, from the posterior pituitary? We talked about that last week in the renal unit. So go back and try to do that. Look at these signs and symptoms. Convince yourself that these are characteristic of endocrine disorders, not enough hormone, and then try to relate the symptom back to the hormone. And then once you see an individual who has panhypopituitarism, you know that they're going to be dependent on hormone supplements. So let's think about this for a second. Let's say, suppose we had a young adult female who became pan-hypopituitary due to a destructive tumor. That tumor was resected, so we got rid of the tumor, but now she's got pituitary dysfunction post-operative. What types of hormones may she have a long-term dependency on, because now she's unable to make those anterior and posterior pituitary hormones? It's a really, really interesting phenomenon, isn't it, when somebody loses a pituitary gland? And there are numbers of reasons why that can happen. We're not going to cover all of them, but I was using the destructive tumor as an example. Individuals can hemorrhage in the pituitary gland. They can stroke the pituitary gland. An abscess can occur, which destroys the pituitary gland, right? So a lot of different pathologies can lead to this. And then finally, let's just briefly talk about metastatic tumors of the brain. These are the most common forms of cancers. Again, metastatic meaning it originated in one organ and then traveled via blood to another organ. Here is an example of a metastatic malignant melanoma. So the melanoma began somewhere on skin, and now you can see various examples, right? You can see a CT scan showing the large tumor in the right frontal lobe. You can see the biopsy of all those malignant melanocytes in the brain parenchyma. And then on the postmortem sections, you can see that tremendous metastasis of multiple invasive malignant melanoma cells all around in the gray matter and in the white matter of those postmortem sections. So a takeaway point here would be most common cancers of the brain, particularly in adults, are metastatic. They've come from another organ. Here we're showing you an example of a melanoma, but again, breast cancer, colon cancer, lung cancer can all metastasize to the brain. And metastatic tumors will also elevate intracranial pressure. Not going to get really deep into managing elevated intracranial pressure, but just really quickly, certainly those of you that are working in neuro intensive care units are doing this on a daily basis. If you're in trauma surgery or emergency medicine, you're probably seeing a lot of neuro trauma that leads to elevated intracranial pressure. So again, number one, pick up on it. Is a patient showing you signs of elevated intracranial pressure? Image that individual, and then do they have something which is something that can be reversible? Do they have a reason to have an immediate neurosurgical consult for a craniotomy so you can decompress and evacuate the tumor or the hematoma, put in a shunt, drain CSF, put in an intraventricular catheter with a transducer so you can start measuring intracranial pressure? Right? That's the only way that we can measure intracranial pressure is with some type of transducer inside the skull. Oxygenation and ventilation, extremely important. Maximizing O2 delivery, protecting the airway and ventilating the patient to a CO2 level of about 30 to 35. We don't want to hyperventilate them. Maintaining normal electrolytes and glucose, maintaining normal blood pressure. Again, normal blood pressure is needed because we want to perfuse the brain. So there's an equation. Cerebral perfusion pressure is mean arterial pressure minus intracranial pressure. So we need that delicate balance of blood pressure, have enough blood pressure to have the mean arterial pressure higher than intracranial pressure so we can continue to perfuse the central nervous system. And you can see by the equation here, if the blood pressure is too low or the intracranial pressure is too high, that's going to adversely affect your ability to get perfusion into the brain. So a lot of different stuff going on in terms of successful management of elevated intracranial pressure, and almost always that's going to require the skills of a neurosurgeon, particularly the craniotomy, to decompress, debulk, evacuate the VP shunt, and the placement of the catheter so we can transduce those pressures and act on those pressures. Okay, moving on here. Alan, a 68-year-old male, he's on medications for type 2 diabetes and hypertension. He now has become anxious and disoriented. He's sweating. He has a very distressed look to himself. He's unable to speak clearly. And then he's having difficulty moving his right hand. What do you think is happening? All right, I hope you all answered CVA, cerebral vascular accident stroke. That's our next topic here. So stroke, impaired perfusion to a isolated region of the brain, can come in two forms: hemorrhagic, bleeding into the brain parenchyma, or ischemic. Thrombus in the arterial flow leads to lack of perfusion, inability to get blood into the brain, right? Inability to get blood if the artery is obstructed, right? Whether it's hemorrhagic or ischemic, that's going to lead to loss of oxygenated delivery of blood and glucose to those metabolically active neurons, and those neurons do not live long without that supply of oxygen and glucose. Within minutes, that damage can become irreversible. So you can block the artery or you can burst the artery. You can have a hemorrhagic stroke or you can have an ischemic stroke, and the consequences are failure to deliver O2 and glucose to highly metabolically active neurons. CVA, cerebral vascular accident, is a loss of blood flow to a region of the brain. It can happen anywhere in the brain. Here is an example of a left-sided frontal parietal stroke. And one of the things that you can see on a CT scan early in an ischemic stroke is a swelling, edema, and a lack of differentiation of the folds and grooves, the gyri and the sulci. So can you pick up on that? Compare the right side of the brain to the left side of the brain in both the axial and the coronal sections, then you should be able to pick out the region where the CVA is occurring. Now remember, because this is happening on the left side of the brain, the right side of the body is affected, right? Contralateral. We'll look at some hemorrhagic strokes in a minute or two here, and how how blood hemorrhage in the brain looks a little bit different than edema due to ischemia. Here's a hemorrhagic stroke in a postmortem section. This is obviously a massive hemorrhagic stroke. Again, this is in the left frontal parietal lobe. I hope you can differentiate that as being frontal parietal. You can also see some hemorrhage in the temporal lobes as well. And then on the axial CT scan, you can see that large frontal lobe hemorrhagic CVA. So on a CT scan, blood tends to look white. So now seeing that white in that frontal lobe, that's going to be characteristic of hemorrhage. Again, blood looks white on a CT scan. These two images are not the same patient, okay? So don't try to match that up. These are different patients. I just wanted to show it to you, hemorrhagic stroke in terms of the post-mortem pathology, and then show you how hemorrhagic stroke looks different on a CT scan versus the ischemic edema that you saw on the previous slide, which is darker in appearance as opposed to white. Okay, we know the risk factors for stroke because we know the risk factors for atherosclerosis. We cover that in a fair amount of detail in the cardiac unit: hypertension, hyperlipidemia, diabetes, obesity, sedentary lifestyle, cigarette smoking, other ones as well. And then with respect to hemorrhagic stroke, individuals who have vascular malformations, such as aneurysms, where the wall of that outpouched blood vessel is going to be weaker, potentially allowing it to rupture, right? So hemorrhagic stroke as a result of rupture of aneurysms, defects, outpouchings of areas of arteries. See the aneurysm there on that angiogram highlighted, circled in yellow, a big, kind of like a big ballooning outpouching of that artery. All right, how do we get blood flow up into the cerebral cortex? Again, the cerebral cortex is frontal lobe, parietal lobe, temporal lobe, occipital lobe. We need to get blood flow every region of the brain, right? Not only the cortex, but also the cerebellum and the brainstem. But let's focus here for a minute on the cerebral cortex. There are three pairs of arteries, the anterior, the middle, and the posterior cerebral artery. So we have left and right-sided, anterior, middle, and cerebral. Deep in the center of the brain, we have a communication, kind of like a roundabout, that we refer to as the circle of Willis. The circle of Willis is made up from the carotid arteries coming up to the brain in front of the neck and the vertebral arteries coming up to the brain in the back of the neck. And eventually those vertebral arteries will fuse, will come together to form a basilar artery, which runs up to the brainstem. And then that basilar artery with the carotid arteries are going to communicate with each other and form this roundabout called the circle of Willis. And that circle of Willis roundabout allows one way to have redundant circulation, redundant availability to get blood flow up into the anterior, middle, and posterior cerebral arteries. We'll look at the circle of Willis a little bit closer. You can see it in here. If you look at right in the center of the brain, you can kind of get an idea of where you can see that circular redundant blood flow. Let's move on, maybe show this to you in a better means. COW, circle of Willis. See it there in the middle of the angiogram? So again, two carotid arteries are going to come up. Two vertebral arteries are going to form the basilar artery, signified there in B. And then the junctions of that basilar with the carotids and communicating arteries in there is going to form the circle. And then off the circle, we're going to have the anterior cerebrals, the middle cerebrals, and the posterior cerebrals. And this yeah, you can see all that. I got it all labeled for you. Anterior, middle, posterior, carotid, circle of Willis, VAs, right vertebral, left vertebral, and right posterior cerebral arteries. So can you see all that? Anterior, middle, and posterior cerebral arteries are the ones that we're going to focus on right now because those are the arteries bringing blood flow to the cerebral cortex. So angiograms and contrast-enhanced MRIs can be used to visualize the arterial blood flow into the brain. So let's see if you can do this using these four photos here. In each of these images, can you identify some of that vasculature? So in image 1, do you see the circle of Willis in the middle cerebral arteries? In image 2, can you see the circle of Willis, the basilar arteries, the vertebral and the carotid arteries? Can you see the anterior and the middle cerebral arteries? In image 3, now we're looking at the base of the brain. Can you see the circle of Willis and the posterior cerebral arteries? Sometimes it's in that inferior image where you see the posterior cerebral arteries best. And then in the fourth image, in the sagittal, you should be able to see the anterior cerebral artery. So I don't think it's too difficult to see all these, and I think it is important for you to understand a little bit about the anatomy. Again, key term there, a little bit. I'm not going to test you into any amazing amount of detail. And again, remember when you do that neuroanatomy test, you get to use references anyway, right? So again, see if you can identify these critical vascular images on these various contrast-enhanced MRIs and the angiogram in photo 2. All right, so cerebral vascular accidents, again, strokes, loss of blood supply. They can be either ischemic due to a clot, or they can be hemorrhage due to vessel rupture. And depending on what it was, it's going to look a little bit different on the CT or MRI, and it could look different as well based on whether or not contrast was used or what type of diffusion image was being used, particularly on an MRI. So what I will do on an exam is I'll show you something like this and I'll say, hey, that's a stroke. And then I'll want you to be able to recognize what region of the brain it is and then take it one step further and be able to tell me what type of clinical picture might you expect from that stroke. I'm not just going to show you a photo with pathology and have you differentiate whether that's ischemic or hemorrhagic. I'm going to kind of tell you what's going on. I want you to be able to pick up the region of the brain it's in and then relay for me what types of signs and symptoms. So as an example, in that far right MRI, if I show you that photo and I say that is a hemorrhagic stroke, can you recognize that that's in the cerebellum? And then once you recognize that it's in the cerebellum, can you tell me what would be the expected signs and symptoms of an individual who has a hemorrhagic stroke in the cerebellum? You'll be able to do this, and we'll work on this as we move through these next couple of slides. But just remember, CVA looks different depending on what type of imaging was used and how the diffusion and the contrast may have been altered on that image. Ischemic stroke can occur due to thrombus. Sometimes that thrombus accumulates initially in the carotid artery, and then it can break off and travel distally. So again, thrombus that breaks off and travels is an embolus. So ischemic stroke in the brain can happen either due to thrombus or due to embolism. When you get thrombus proximal to the circle of Willis, so in the carotid or vertebral or basilar arteries, that circle of Willis can help with redundant blood flow, so you continue to maintain perfusion to the region of the brain, right? So if you've got a thrombus in the right carotid artery and you've got poor blood flow coming through the right carotid artery due to fixed thrombus, you may still have good blood flow to the right side of the brain due to the redundant circulation around the circle of Willis, all right? But once you get thrombus or hemorrhage in an artery distal, right, then there's no redundant circulation, right? So if you get ischemic in the left anterior cerebral artery, you're distal to the circle of Willis. Now you don't have that redundant circulatory protection. Does that make sense, right? Circle of Willis is good if you've got obstruction of blood flow before going into the circle, but once you leave the circle, then you don't get that benefit of redundant circulation. So CVA is infarction of brain tissue due to occlusion of blood vessel or rupture of blood vessel. After about 5 minutes of ischemia, irreversible neuron damage can occur. Necrosis of the brain parenchyma, edema of the brain parenchyma. Swelling and edema can raise intracranial pressure. And then eventually that infarcted region can be surrounded by areas of inflammation. Some of that inflammatory zone surrounding the infarct can regain function, and the term that they use for that surrounding region of the ischemic infarct is referred to as the penumbra. Okay? Central area is going to have neuron death due to necrosis. The surrounding region, due to edema and incomplete ischemia, may be able to restore blood flow and may be able to show recovery. Why do the neurons die? So loss of oxygen, the loss of glucose, the loss of nutrient, the inability to make ATP will lead to cell membrane dysfunction that will lead to cell death. As the cell dies, it releases intracellular components like arachidonic acid, electrolytes, and protein. That's going to draw fluid in that can lead to diffuse or localized cerebral edema. That edema can further elevate intracranial pressure, further leading to impingement of blood flow and worsening cerebral herniation. And weeks after the infarct, there may be revascularization and inflammatory scarring. So in these two photos here on the right, showing you a post-mortem hemorrhagic stroke, and on the left showing you a post-mortem ischemic stroke, and you can see the regions of cellular necrosis where there has been complete ischemia. Okay, FAST, face drooping, arm weakness, speech difficulty, time to call 911, spotting a stroke, right? Symptoms of a stroke: altered mental status, hemiplegia, weakness on one side of the body, paresthesias, loss of sensation in one part of the body, aphasias, inability to communicate, either because you don't understand what's being told you, something being told to you, receptive aphasia, or inability to communicate to someone, get something out and say it, expressive aphasia, and then obviously visual disturbances depending on what region of the brain, particularly if it's the occipital lobe or involving one of the optic tracts. So the signs and symptoms that an individual develops due to a stroke is due to the location of the injury. And again, I wrote on here location of the ischemic injury, but again, it can also be hemorrhagic injury as well. So signs and symptoms of a stroke. A massive stroke can certainly lead to sudden death. A massive stroke can certainly lead to coma and profound altered mental status changes, but the hallmark signs of strokes is acute hemiplegia with muscular rigidity. And remember, that's contralateral. So in this MRI, if I told you that this person, that white area was a stroke, was an ischemic stroke, so it's happening, can you determine what lobe that's happening in? You can certainly determine the side of the brain, so it's right side of the brain. What side of the body is affected? Contralateral, right, left. So visual losses, cognitive changes, the aphasias, receptive or expressive, dysarthria, difficulty talking, dysphagia, difficulty swallowing, unilateral paresthesias, numbness and tingling, loss of sensation on one side of the body, facial paralysis, dizziness, ataxia. Again, all depending on what part of the brain is being affected, different clinical signs and symptoms. So look at each of these. One's a post-mortem section, the other is a CT scan. And if I told you that each of these were due to a stroke, can you tell me what lobe we're in, what side of the body we're affecting, and then eventually you'll be able to tell me which of the main arteries, anterior, middle, or posterior cerebral arteries, were primarily affected. So let's move on a little bit, talk more about some of this anatomy and see if we can differentiate then what would we expect in terms of signs and symptoms if we were shown a stroke on an image, or if we had signs and symptoms, try to predict where that stroke would be in the brain. It's a little difficult, but we can get through it. Let's see if we can do this. One of the things that you want to be able to do is what is called mapping the brain. So mapping the brain is not only identifying critical regions of the brain, but then what parts of the brain are responsible for certain function. So frontal lobe, responsible for intellect, personality, cognitive thought. The frontal lobe has the motor cortex, which initiates motor movement. The parietal lobe is all about sensation around the body. Broca's area of the frontal lobe, the production of speech. Wernicke's area of the temporal lobe, the reception and the understanding of speech. An auditory region in the temporal lobe where we hear. A memory storage region in the temporal lobe where we store short and long-term memory. The occipital lobe is all about visual, picking up and recognizing visual images, visual memory. The cerebellum is all about balance, coordination. And then in the brainstem, those vital cardiorespiratory autonomic centers. So we're going to use this diagram here to really, at a high overview, determine what different regions of the brain are responsible for what physiologic functions. And one of the two things that we really want to pay attention to here is, where do we get motor activity? Where do we perceive sensory activity? Where do we perceive vision? Where do we initiate speech? Broca's region of the frontal lobe. And then where do we understand speech and communication? Wernicke's area of the temporal lobe. Signs and symptoms of a stroke are dependent on what region of the brain has been affected. So we have a sensory cortex and a motor cortex, where the motor cortex is where we initiate movement. So if I want to move my right thumb up and down, that has to initiate in a region of the brain dedicated for my right thumb on the motor cortex. And then if I want to feel sensation in my right thumb, a sensory input would be applied to my right thumb, such as a squeeze or a prick or whatever it might be. And that sensation has to get up to my brain, to the region of my brain in the sensory cortex dedicated for my right thumb, so I can perceive it and localize it. I just got a needle prick on my right thumb. That sensation of the needle prick and the location of that sensation needs to ascend up to my brain to the sensory cortex. We have a motor cortex and the sensory cortex. And on each of those, we have certain regions of the brain dedicated to that region of the body. And we have more region dedicated to face and hands in the motor cortex and in the sensory cortex than we have for other parts of the body. And it layers out, that layering out of the brain geography, which corresponds to the region of the body, we refer to that as the homunculus. And we have a motor homunculus and the sensory homunculus. They're a little bit different, but or for all practical purposes, we'll consider them to be similar. And the motor and the sensory homunculus say that we've got more region in the brain dedicated to the head and neck and face and the hands than we have to other areas of the body. And it kind of distributes and layers out over the motor cortex and over the sensory cortex. And you can see how that layers out in the graphic. if you look at the motor cortex in the frontal lobe or the sensory cortex in the parietal lobe, you can see that genitalia, feet, legs are more medial. Arms, hands, and face are out more lateral. Okay? See what I mean? We're looking at one side of the cerebral cortex. We're looking at the right hemisphere. So medial towards the inner part of the brain, that region more dedicated to the lower extremity genitalia. The outer, more lateral regions taking up more space for head and neck, face, hand, and arm. Okay? And that's the homunculus. A large stroke can affect multiple regions of the sensory and motor cortex, giving the individual diffuse symptoms, or an entire side of the body may be infected. A smaller stroke, which only affects a select region of the brain, may only infect one area of the body, such as one part of the face or just parts of the hand, right? Is this kind of making sense? A lot of region of the brain for hand and face, smaller regions of the brain for extremities. Big stroke, a stroke that affects a large region of the cortex, can affect a large region of the body. A smaller stroke that only affects a select region of the motor or sensory cortex, only going to affect smaller parts of the body. And again, that is contralateral. So take a look at the homunculus. If our bodies were built like the geography of our brain, that's what we would look like. Okay, that would be kind of creepy, wouldn't it? Everybody walking around like that, kind of be weird, right? So more region to the brain for those more critical areas of the body, hands, particularly hands and face, right? The homunculus, the humungus. Did you guys watch the Mad Max movies? Mad Max Part 2, there was this giant guy called the humungus. Okay, don't confuse the homunculus, the geographic region of the brain for our body, with the character in the Mel Gibson movies, Mad Max, the Road Warrior. Sorry, I had to put that in there. I'm starting to lose my mind here. We're an hour and 45 minutes into this dictation. We're still going. See, I told you the neuro unit was going to be really long, so I just had to throw something in there for a minute for a brain relief. All right, let's get back. All right, so now vascular distribution. So we looked at the geography of the brain in terms of geography dedicated to certain parts of the body. Now let's look at the three arteries of the cerebral cortex, anterior, middle, and cerebral. You can see that the anterior cerebral artery is primarily out in the medial aspect of the brain. The middle cerebral artery is out in the lateral aspect of the brain, and the posterior cerebral artery is in the backward, so in the inferior and posterior regions of the brain. So now match that up in terms of lobes, right? You can see that the anterior cerebral has the medial aspects of the frontal and parietal. The middle cerebral artery has the lateral aspects of the frontal, parietal, and temporal. And the posterior cerebral artery has the occipital lobe and the inferior regions of the temporal lobe. And when we put that together with the homunculus, we can start to understand why certain vascular pathologies, strokes of the different cerebral arteries, can lead to different clinical manifestations, because those cerebral arteries are supplying and perfusing different regions of those 4 lobes of the cerebral hemispheres. 2 important regions, Broca's area in the frontal lobe, where we have expressive speech, our ability to talk, and Wernicke's area of the temporal lobe, where we have the ability to receive communication and understand verbal communication. So receptive aphasias can occur due to strokes which happen in the temporal lobe, and expressive aphasias can occur due to strokes which happen in the frontal lobe. So if I say something to you and you can't understand it, that would be a receptive aphasia. If I say something to you and you understand it, but you can't verbalize back to me, that would be an expressive aphasia. So Broca's in the frontal and Wernicke's in the temporal lobes. So now to help you out with determining where a stroke is occurring and what are the signs and symptoms of certain types of either thrombus or hemorrhage in those 3 cerebral arteries, you're going to map this cortex. So we got frontal lobe in blue, parietal lobe in yellow, occipital lobe in pink, and temporal lobe in green. And then you can see the cerebellum underneath, and then the brainstem completely white underneath the cerebellum. Print a couple of these out and then start highlighting, find Broca's area, find Wernicke's area, find the motor cortex, find the sensory cortex, which region of the brain is responsible for personality, thought, cognition, which region of the brain is responsible for storing memory, which region of the brain allows you to recognize visual images. So that will help you map the cortex, right? Understanding, where some of those critical things are coming from. And then you can start thinking about neurologic signs and symptoms and where that's coming from. So you've labeled the lobes, the brainstem, the cerebellum. You've wrote down critical functions for each. You've identified the motor and where's the motor homunculus and where's the sensory homunculus. The motor cortex is in the frontal lobe. The sensory cortex is in the parietal lobe. And now let's take these individuals and can you pinpoint on the brain where the stroke is occurring? So person can't maintain balance. Another person can't recognize objects by sight. One person can't talk. One person can't understand speech. One person has arm and leg paralysis. Another person has leg paralysis. Arm and hand paralysis. The other one has just leg paralysis. One person can't hear. One person can't swallow and has facial paralysis. So you think you can do that by mapping out the cortex? Do you think that you can find those critical regions of the brain responsible for that? And then once you've done that, can you determine, is that coming from anterior, middle, or posterior cerebral arteries? Sounds like a handful, right? For those of you guys that are really into neuro and doing this every day, you probably have already got that done. But if you haven't done this and you haven't thought about this for a while, it takes some time, and that's okay. Take some time with that cortex map. Go back, look at that anatomy again, and see if you can put that all together. I will have you do that in some cases on the quiz and on the exam. But again, with respect to the quizzes, you are going to be able to use references. So let's try this. Here's 5 different pictures of a CVA. The CVA is each of these CVAs are in different regions of the brain. So can you determine of these which one has a visual deficit, which one has right leg paralysis, which one has ataxia, which one has right face and hand paralysis, and which one has a receptive aphasia? Can't understand speech coming in. This will be the most difficult that I will make it, okay? If you can do this, then you will be able to do any of these stroke scenarios that I could potentially give you on a quiz or an exam. So take your time. I know you can do it if you're having problems. Put the question up the blackboard or just email me directly and we'll get you through it. Okay, pediatrics and strokes. Kids have clean arteries. Kids are far less likely to have atherosclerotic ischemic stroke compared to an adult. In kids, you see more hemorrhagic stroke than you see ischemic stroke. What are some reasons that kids have strokes? Congenital aneurysms, preterm infants who develop intraventricular hemorrhage, babies who develop hemorrhage due to being shaken. Shaken infant syndrome is due to cerebral hemorrhage. Sickle cell disease, where the child has sludging of blood cells. Congenital heart anomalies, which can lead to emboli. Congenital coagulopathies can lead to strokes in kids. Hemolytic uremic syndrome, another genetic disease where there's inflammation of blood vessels, moyamoya disease. So there's a number. So I guess what I'm saying in this slide is babies and children are not immune to stroke. It's very unlikely to see ischemic atherosclerotic stroke in babies and children. It is more likely to see hemorrhagic stroke, either due to congenital malformations, preterm infants having intraventricular hemorrhage, infants who have been abused and shaken. Some select diseases which begin in pediatrics, like sickle cell disease, and some of the genetic coagulopathies typically present in childhood, particularly with sickle cell disease. Young children can develop stroke due to sludging of those sickle cells in the arterioles. So just be aware of some of the differences in pediatrics versus adults when it comes to etiologies of stroke. And then I'm sure many of you have used TPA in individuals who've presented with ischemic stroke. So the idea there is TPA activating the plasmin enzyme and starting to degrade the thrombus or the embolus can restore circulatory flow to regions of the brain affected by an ischemic stroke. You cannot do this with hemorrhagic stroke, right? TPA will just make the hemorrhage worse. And TPA has been shown in numbers of studies to show improved neurologic outcomes at day 1 and 3 months after a stroke. You got to rule out the CNS bleed. You got to rule out contraindications to TPA prior to giving it. You usually have about 3 hours before after the onset of symptoms for this to be effective, positively effective, and best done through emergency departments and centers which are accredited as stroke centers. So I believe I do have a discussion thread in Blackboard for those of you who have been involved in this to give us a case and tell us a little bit about your experience with a patient who received TPA for an ischemic stroke. All right, we're going to get off strokes and we're going to come back, and once again, let's look at this neuron. We got an input region a delivery region, which is the axon, and then that axon is sending that electrical message to the output region. Myelin is wrapping around the axon, and myelin is enhancing the efficiency and the speed of the delivery of that electrical message. And we call that electrical message the action potential. So here we have a neuron delivering an action potential. So some type of stimulus comes into the left side of that neuron, being shown by red and blue dots. That message is picked up at the input section, converted at that initial segment into an electrical action called the action potential. That electrical action is delivered down the axon to the output region to the terminal. So that action potential, that electrical message, is delivered down the axon, and that's a one-way street. It can only go one way, from cell body to terminal. It cannot reverse. And that movement of electrical activity is done solely through the opening and closing of ion channels, two in particular, sodium and potassium. So that electrical activity has a stimulating phase called depolarization, DE, and it has an inhibitory phase called repolarization, RE. The stimulation phase is due to sodium coming into the cell. The inhibitory phase is due to potassium leaving the cell. So we get that neuron to fire by stimulating it, making it more positive, getting sodium coming in, and then we inhibit that neuron by making it more negative. To stimulate a neuron, make the electrical activity inside the neuron more positive. To inhibit the neuron, make the electrical activity in the neuron more negative. And that's important to talk about that for a little bit, because we want to talk about drugs eventually as they stimulate neurons and drugs as they inhibit neurons. What do you think? If you give somebody a sedative drug like midazolam, what's going on in their neurons? Are you making it more positive or more negative? Right, you're inhibiting them. You're making them more negative. So stimulation, make the neuron more positive. Inhibition, make the neuron more electronegative. And the transfer of that electrical message, called the action potential, has a leading stimulatory phase where the neuron's getting more positive due to sodium coming in, and then refractory, inhibitory, more negative as potassium is leaving. And then there's going to be an enzyme in there called sodium potassium ATPase, which is going to re-equilibrate everything so the neuron is capable of firing again. You can only fire one action potential at a time. You can fire them very fast and very repetitively. It's really quickly how it happens, but you can only fire one at a time because you do have that inhibitory phase, that repolarization phase. Don't spend too much time on here. This is graphing out the electrical action potential. It shows you as you put sodium in, you're depolarizing, making the neuron more negative, more positive and firing. As you take potassium out of the neuron, you're making it more negative and inhibiting it. And at the end, there's going to be an enzyme, a sodium potassium ATPase pump, which is going to re-equilibrate everything so that you can fire the next action potential. These neurons can be these axons of neurons can be very, very short, where the action potential only travels a couple of microns, or these action potentials can be these axons can be very long, such as axons in the spinal cord, where this action potential can be delivered over meters. Okay? The action potential, again, is just the electrical activity of the neuron being carried from one site to another along the axon. And again, moving that action potential, moving that electrical message happens through ion channels. And there are a lot of drugs that have their effect on ion channels. And by changing the permeability of the ion channel can alter whether or not the action potential gets moved in the first place. So in this example with lidocaine, where the dentist or the oral surgeon is injecting lidocaine into a peripheral nerve, that lidocaine is going to block sodium ion channels, and by blocking the sodium ion channels, the action potentials can't transfer. So in this case, he's going to apply the physical stimulus, drilling into the teeth. The dendrites should pick that up and send that electronic message to the brain, to the sensory homunculus, and make her aware of the pain happening due to the drilling in the teeth. But going to interrupt that with lidocaine by giving a drug into that peripheral nerve, which is going to block permeability in the sodium ions. When you block that permeability, you can't transfer that action potential. So therefore, he can drill in her teeth, and she doesn't feel that painful drill because that action potential can't get that message to her sensory homunculus. Kind of cool, right? All right, since we're talking about electrical activity, we got to talk about our next pathology and talk about seizures. Seizures are electrical hyperstimulation of the cortex. They're transient, they're uncontrolled, they're paroxysmal, they just suddenly occur. And what do you think? Is a seizure depolarization of the neuron or repolarization of the neuron? So think of it. Hyperstimulatory electrical activity, what are we doing to the neuron? Depolarizing it or repolarizing it? Depolarizing, right? Making it more positive, giving it more stimulus. So the seizure is the hyperelectrical stimulation of the cortex. The convulsion then is the physical manifestation of all that abnormal electrical activity, right? So you got somebody who's got this sudden electrical discharge of action potentials in the cerebral cortex. And now as a result of that, neurons get stimulated, and the stimulation of that neurons is going to lead to uncontrolled abnormal motor activity of the body. That's the convulsion. And then we use the term epilepsy for individuals who have a long-term condition with an enhanced tendency towards developing seizures. A lot of people use seizure and convulsion interchangeably. Again, in terms of proper terminology, we should refer to the seizure as the electrical activity happening in the cortex, that electrical activity that you can see occurring on an EEG, and then the convulsion, the physical manifestation of that electrical activity. So neurons are constantly creating action potentials. We have a variety of different types of action potentials which are occurring in all these neurons in the brain. And just like action potentials are being manifested by the conduction system in the heart, we can transduce that to an EKG or ECG, electrocardiogram. Same thing with transcutaneous blades on the scalp. We can transduce those action potentials into an EEG waveform. There's no way we're going to talk about all the different waveforms of an EEG. That's for a neurologist. But the thing that I want to convince you of is those electrical activities can be picked up on the transcutaneous monitors of the EEG. And for an individual who suddenly develops aberrant, paroxysmal, uncontrolled electrical activity, that can be picked up in an EEG, and we can see that seizure, that abnormal electrical activity on the EEG, right? So on the left side of this EEG graph, we can see normal electrical activity, and then as we move to the right where we see that hyperfunctional electrical activity, that may be an example of what the EEG looks like in an individual experiencing a seizure. If the seizure is focal, only happening in one region of the brain, maybe only some leads are affected. If the seizure is generalized, particularly if the seizure is generalized, affecting all the regions of the cortex, then all the leads of the EEG are going to show the electrical activity. So focal seizures, just one area of the cortex; generalized seizures, the entire cortex. And that can be determined by looking at an EEG, which leads are affected. Most seizures are idiopathic, meaning we really never find a cause in terms of why the individual has the seizures. Some individuals have secondary causes of seizures, brain lesions, including tumors and strokes, elevated intracranial pressure, metabolic abnormalities such as low glucose, low sodium, particularly in children, febrile seizures, drug intoxications, anxiety, stress, psychiatric disorders, CNS infections like meningitis, head trauma, post-concussive seizures, or seizures due to bleeding on the brain, strokes, and photogenic, right? So there's a fairly long list in terms of why an individual may be having seizures. So the individual who presents with new onset seizures typically is going to go through some type of workup to determine if they have an underlying cause. Sometimes that cause isn't found, and then that's referred to as idiopathic, okay? So it is important, somebody comes in with a seizure, what's causing this? Do we have a reason for the seizure to be occurring? Let's identify it, try to reverse it if we can. You know, critical is a person hypoglycemic or hyponatremic under the influence of a drug, brain trauma, right? Something that we could do something about. But many seizures are idiopathic. You just never find a underlying cause. Imaging is important to look for anatomic variations or anatomic pathologies in the cortex that can lead to seizures. If you look at this MRI, again, MRIs are far more detailed than CT scans. A CT scan is good for looking at, excuse me here, talking way too dang much here. CT scans are good for looking at things like bleeding and tumors, but MRIs can pick up more isolated anatomic pathologies, such as a scar. Take a look in the red here. Look on the right side of this individual's cortex versus the left side. Can you see like that, what they would call a white matter lesion? The imaging here has been reversed a bit in terms of white matter, gray matter. So in this MRI, the white matter looks really dark and the gray matter looks really light. But can you see the difference between the right and the left side? You see that subtle little white matter lesion in there? May refer to that as white matter plaque or white matter scarring. That might be a pathologic segment responsible for a seizure. So MRI imaging getting better and better at being, you know, as MRIs have advanced from the late 80s and early 90s to what we're dealing with now. The detail and the resolution of these MRIs can now start picking up small anatomic variants and small anatomic pathologic scars, etc., which may be the source of an individual suffering from either a focal or a generalized seizure. This was a nice example of an MRI doing that. Okay, classifying seizures. We said they're partial if they're localized to one area of the brain. They're generalized if they occur in both hemispheres. A complex seizure is a person who has a seizure and loses consciousness. A simple seizure is an individual who's still awake and alert during the seizure. Idiopathic, no known cause. Secondary seizure is due to a reversible identified cause. Person has an aura if they have a pre-sensation of an onset of a seizure. That may be a visual aura, an auditory aura. Tonic is a rigid convulsion. Clonic is a rhythmic convulsion. Flaccid is a loss of tone. And then post-ictal refers to once the seizure is completed, the individual may have a period of time where they're still unresponsive and lethargic. We usually refer to that as the post-ictal phase. So an individual can have a generalized, complex, idiopathic, tonic-clonic seizure, right? So you got to put all this together to try to describe what type of seizure an individual had. If an individual had a seizure that was only found to be in one part of the left frontal lobe, which caused the individual to have a convulsion just in the right hand, and they were awake and alert during that process, how would you classify that? Go back and listen to that again. I would call that a partial, simple, tonic-clonic seizure, right? Partial because it was only in the frontal lobe, simple because the person didn't lose consciousness. Tonic-clonic because it was rhythmic, hypertonic shaking of that hand and arm. All right, so be familiar with this some of this simple classification of seizures. Remember, there are some seizures which are idiopathic. You don't find a reason for it to happen, but nonetheless, seizures can also be due to secondary reversible causes. You want to find that out. You don't want somebody having a prolonged seizure where you missed an underlying secondary reversible cause, and as a result, the person ended up with permanent neurologic disability. You might be referred to as the defendant in that person's lawsuit, right? Well, you know what I'm talking about, right? Somebody has seizures, you got to do some stuff to determine whether or not you've got a reversible cause and reverse that cause. So things like shock, elevated intracranial pressure, meningitis, low glucose, low sodium, other electrolyte disorders, drug overdoses, which you may need to drug overdoses or adverse drug effects that you may need to intervene on, right? That should all kind of be standard in terms of evaluating an individual who you're resuscitating, who's having an active seizure or had a seizure, and now you're seeing them in that post-ictal phase. So some critical things that you need to be thinking about. All right, really quickly, let's just look at drugs. There are numerous different types of anticonvulsant drugs that are out there for either stopping a seizure which is occurring or for prophylaxing a seizure, stopping an individual from having further seizures, prophylaxis, daily use. Ion channels are often the target of these anticonvulsant drugs, so sodium, calcium, chloride ion channels, and another sodium, calcium, and chloride ion channels are frequently targeted ion channels of a lot of these anticonvulsant drugs. Some of these anticonvulsant drugs also target a neurotransmitter called glutamate. We haven't talked too much yet about neurotransmitters. Hold on to that. We'll get to that in Unit 2. Don't memorize any of this. I'm just kind of showing this to you for information only. I'm not going to test you on mechanisms of actions of anticonvulsant drugs, but be aware electrical activity is due to altering permeability in these ion channels, so therefore we can stop or hinder some of that electrical activity by using drugs which affect these different types of ion channels in the brain. And you can see some drugs only have effect on one mechanism of action. Some of these drugs have multiple mechanisms of action. If you look at valproate, and you see that valproate can inhibit sodium channels, calcium channels, and can also affect GABA chloride ion channels, we would say that drug is pleiotropic. It has more than one mechanism of action. So if a person is not actively seizing, we can give them an anticonvulsant drug for prophylaxis if it's indicated. Try to prevent further seizures or try to minimize the duration of a seizure if one occurs. How do you choose a drug? How do they choose a drug? It's all dependent on what type of seizure they're having, how that seizure is classified, their underlying state of health, other drugs they're on that can cause drug-drug interactions, allergies. Are they going to be compliant to a drug if it's a once-a-day option versus a 3-time-a-day option? And more recently, using pharmacogenetic testing. Hopefully you'll hear more about that in your pharmacology course. Trying to determine genetically how an individual may metabolize a drug. And pharmacogenetics is now starting to be used more and more in selecting drugs for seizure prophylaxis. So it's not like you just go to the shelf and pick an anticonvulsant drug and it's going to be effective for everybody. There's a lot of thought that needs to go into which of these different anticonvulsant drugs may be selected to prophylax an individual from having further seizures. Status epilepticus is a term given to an individual who has a life-threatening seizure where that seizure has been going on for more than 5 minutes and that individual is not regaining consciousness. So a lot of you have actively resuscitated people in status epilepticus. You know the important parts of that are airway, ventilating the patient, nothing in the mouth, keeping them safe, oral suctioning, checking a DEXI stick because of hypoglycemia, pulse oximetry and monitoring oxygenation, right? We want to make sure that they're not having one of those metabolic catastrophes that we showed a couple slides back. But in terms of medications, maybe our best and first-line drugs for status epilepticus are the benzodiazepines. Midazolam, Versed, lorazepam, Ativan, diazepam, Valium, probably the 3 most commonly used benzos. They can be given IM, IN, IV, PR, a lot of different ways to get a benzo into an individual. Those are pretty rapidly acting drugs. They cross the blood-brain barrier fairly quickly, and their effect is on chloride ion channels. They allow the chloride ion channel to open and you get more chloride, negative charge chloride into the neuron. That makes the neuron more electronegative, and remember, making the neuron more electronegative inhibits the neuron. Again, seizure is too much stimulation, so we want to stimulate it. Sorry, back it up. Seizure is too much electrical stimulation, so you want to inhibit it. You need to make it more electronegative. And that's what benzodiazepines do. They put more chloride, more negative charged ion into that neuron and inhibit its firing. Very effective for stopping status epilepticus. Other IV options are available, and there's some hardcore things that can be done when even the secondary drugs don't work, like propofol and general anesthesia. So again, not a course here on how to manage status epilepticus, but I wanted to bring that home to show you the importance of electronegativity, all these drugs that can be used for status epilepticus make the neuron more electronegative. And now here's an opportunity for you in one of the discussion threads to talk about an individual that you managed in status epilepticus, what was causing it, and how did you go about managing that individual. Okay, let's keep moving on. Let's talk about head injury here, and let's go through the difference between concussion versus intracerebral hemorrhage. All right, here's a scenario. During a WIA sectional, Tim blocks a free kick with his frontal skull, is knocked to the ground, is unconscious for 45 to 60 seconds. He regains consciousness, is helped off the field. On the sidelines, he cannot recall how the injury occurred. He doesn't remember coming off the field. He's brought to the emergency department. He does recall the ambulance ride to local emergency department, but he's confused in terms of the day and the time. He can recall his name. He can recall his coach's name. What type of injury does Tim have here? Does he have a concussion or does he have intracranial hemorrhage, and what's the difference between the two? So concussion, also known as mild traumatic brain injury, is a transient loss of cerebral function following a blunt hit. Key here being blunt, not penetrating. Gross anatomic injury of the brain is not seen, but microscopic injury to neuron axons does occur. So if you see gross anatomic injury of the brain, particularly bleeding, then you've got intracerebral hemorrhage. An individual who has blunt trauma, who has transient loss of cerebral function, change in mental status, inability to recall memory, has suffered a concussion, and that concussion is usually due to microscopic neural injury which occurs at axons. Blunt trauma can come in one of two different types, accelerating and decelerating injuries. So accelerating injury, something hits the head, such as a punch to the head. A decelerating injury, the head hits something like a head going into a windshield or a head going into the ground. Forces inside the brain, forces inside the skull of that brain being shifted due to the blunt force can lead to microscopic injuries on axons, producing that transient dysfunction, transient cerebral dysfunction. Concussion is graded based on the severity of the symptoms and based on the duration of the symptoms. And the higher the grade, the greater is the risk of intracranial hemorrhage. So an individual who has very mild transient symptoms of a concussion may not be at high risk of intracerebral hemorrhage versus the individual who had profound and prolonged symptoms. Those are the persons that you need to image to rule out intracranial hemorrhage. So in concussion alone, there should be an absence of gross intracranial injury, bleeding. But microscopic injury is there, and that comes due to neuron axonal shearing. Here is a listing of all the different types of symptoms that one can see after concussion. You can see that mental status is important, headache, nausea, and vomiting, ability to recall short and long term, the ability to recall events that happened after the injury versus events that happened before the injury, right? And then a number of long-term consequences of acute concussion, then shown in the second list of symptoms: concentration difficulty, balance, sensitivity to light, ringing ears. So we can see both acute symptoms of the concussion and delayed symptoms or delayed consequences of the concussion, which may last for hours, days, or even weeks after that blunt injury. Now, a different entity here, what we have is intracranial hemorrhage, bleeding in or around the brain, bleeding inside the skull. Bleeding inside the skull can occur on top of the brain. So we have epidural hematomas occurring above the dura, subdural hematomas occurring below the dura. We can have subarachnoid hemorrhage happening in the subarachnoid space. Those would all be examples of bleeding on top of the brain. And then we can have intraparenchymal bleeding, so bleeding which is actually occurring in the gray and white matter of the brain. How do we determine if an individual who's had blunt head injury is at risk for or has intracranial hemorrhage? You got to do imaging studies, immediately a CT scan. CT scans are very good at picking up blood. Blood on a CT scan typically looks white in the early stages. How do we know when to scan? Well, if somebody has had blunt head trauma and they have no concussive symptoms and no signs of external injury, could probably say that they have very minimal incidence of having an intracranial hemorrhage. It's individuals who've had profound mechanism, individuals who've developed concussive symptoms, particularly the higher grade concussive symptoms and where those symptoms have lasted for more than a couple of, certainly for more than a couple of minutes. Those are individuals that we should be considering getting urgent medical imaging on to rule out intracranial hemorrhage. Again, the imaging does not show us a concussion. The concussion is the symptoms. The medical imaging is to rule out intracranial hemorrhage. And here you can see an epidural hematoma, an acute epidural hematoma on a CT scan. See the blood. Again, blood looks white. And here might be a chronic subdural hematoma. Blood may have started the resorptive process, and now that mass lesion tends to look a little bit darker. So epidurals and subdural hematomas, both are equally dangerous. Both can lead to midline shifting, and both may require the individual going to the OR with the neurosurgeon for evacuation. So at least what you should know is the difference between the two locations, epidural versus subdural. Epidural above the dura, subdural below the dural covering. Each one may look a little bit different in terms of the concave versus convex pattern of the blood pushing into the brain. Sometimes you can be fooled by that, but in terms of this course and quizzes and exams, at least you need to be able to define what is the difference anatomically between an epidural hematoma and a subdural hematoma, but recognize that each are mass lesions, increasing volume, raising intracranial pressure. Severe ones can lead to midline shift and herniation. If you look at the photo of the epidural hematoma on the left, can you appreciate some lateral to medial midline shift? It's kind of subtle, but it's there. Can you see that? Hope you can. All right, again, when do we image? Penetrating trauma is a no-brainer, right? If you've penetrated the skull with whatever, you got to image that, right? Blunt trauma is where we got to think about, okay, how significant was the mechanism? What's the severity and the duration of the symptoms? Very important is the persistence of altered mental status. Somebody's had blunt head injury and they have persistent alteration of mental status. You should really be considering putting that person in the CT scanner. Palpable skull trauma, right? If you can palpate a skull fracture, to the CT scanner. Remember, epidural versus subdural hematomas, the differences in the locations. And again, both can be very rapidly progressing. So I've got some CT scans for you there. And I'm showing you some subdural hematomas and some epidural hematomas designated by S and E. And again, you can see the differences, again, in terms of whether or not the blood is layering out in a convex versus a concave pattern. Okay, intracranial hemorrhage, bleeding inside the skull. That bleeding can be due to either traumatic or non-traumatic causes. That bleeding can happen on top of the brain, such as being epidural or subdural, and that bleeding can occur within the parenchyma of the brain as well. So take a look. There's a number of different reasons why an individual may have non-traumatic bleeding into the brain or into the subarachnoid region of the brain. Aneurysms, AV malformations, individuals with congenital bleeding disorders, profound hypertension, chronic alcoholism, connective tissue disorders, individuals on antiplatelet or anticoagulant therapy, and very preterm infants who spontaneously develop periventricular and intraventricular hemorrhage. So on the scans here, we show a CT scan of an intraparenchymal hemorrhage in the region of the basal ganglia. We're going to cover what is the basal ganglia in the next PowerPoint. You can see a large aneurysm there waiting to burst, right? That would cause, depending on where that aneurysm is located, you may see bleeding in the parenchyma or bleeding in the subarachnoid or bleeding in the sub or epidural regions. And then the ultrasound shows an intraventricular hemorrhage. The white arrow is showing you the hemorrhage in and around the ventricle of that small preterm infant. And that ultrasound was obtained by doing an ultrasound through the open anterior fontanelle of the skull. So being a preterm infant is tough. We're not going to talk a lot about premature infants. Premature infants have a very hard time making it due to pulmonary disease, respiratory distress syndrome due to lack of surfactant, sepsis, which may occur due to their immune suppressed state and the fact that they usually have invasive technology in the forms of catheters, etc. And then they have a very brittle, very fragile CNS capillaries, particularly capillaries surrounding the ventricular regions of the brain. And changes in blood pressure, changes in O2 concentrations, a lot of different things can lead the preterm infant to spontaneously hemorrhage into and around the ventricle. So if you look at this very small preterm infant on a ventilator, you know, fighting for life with all the different complications that are going on, all these different complications can increase that person's risk of intraventricular hemorrhage. And there you can see a number of different post-mortem specimens showing you the preterm infant brain, and you can see varying degrees of intraventricular hemorrhage in each of those different sections. So a lot of those preterm infants are followed daily or weekly with ultrasounds through the anterior fontanelle. Bring the ultrasound machine to the bedside. There's no radiation exposure. Don't need to move the infant. You can put the probe on the anterior fontanelle and then look at the ventricles and then look to see whether or not those ventricles are changing with respect to the potential for bleeding or hydrocephalus, etc. And for those infants that do recover and survive an intraventricular hemorrhage, as you can imagine, there can be many different types of long-term neurologic complications as a result of that type of brain injury. Cerebral aneurysms, localized dilation of an artery, weakened arterial walls, have an increase of bursting and causing hemorrhagic stroke. Many of these aneurysms occur at bifurcations of arteries, and in the cartoon graphic here you can see some sites which are known to be at increased risk of developing an aneurysm. As that aneurysm grows in size, that can raise intracranial pressure, that can place compression on surrounding structures. Anterior cerebral arteries and internal carotid arteries are common sites for these aneurysms. Highest incidence of an aneurysm rupture occurs after the age of 50. Females tend to have a higher risk than males. Certain diseases that raise vascular risk, such as diabetes and hypertension, can increase that risk of hemorrhagic stroke, and sometimes certain types of disorders of collagen and connective tissue can also lead to increased risk of aneurysm. Spontaneous subarachnoid hemorrhage can also occur. Individuals can experience sudden, severe onset of headache, sometimes rupture, sometimes bleeding into the subarachnoid space can be due to rupture of a congenital aneurysm or due to bleeding of some type of arterial venous malformation. Non-contrast CT scan picks up blood, right? And you can see in all these CT scans, you can see varying degrees of blood within the subarachnoid space, between the cerebral hemispheres, within the sylvan fissure, between the temporal lobe and the upper cerebral cortex. You can see subarachnoid hemorrhage in some of the sulci or within some of the folds of the brain. And then that very last CT scan, you can see profound hemorrhage with profound edema. If you were to do a lumbar puncture, because the bleeding is into the subarachnoid space, and in the subarachnoid space is where we collect CSF, you would be able to find red blood cells in the CSF of an individual who suffered a spontaneous subarachnoid hemorrhage. These are much more common in adults than they are in pediatrics. All right, last thing we're going to talk about are migraine headaches. And in order to talk about migraine headaches, we got to talk a little bit about synapses and neurotransmitters. So, moving a message from one region of the nervous system to another, moving it occurs on axons, but sometimes it's just not one axon that goes from one region to the next. Sometimes you need to have a series of neurons chained together, moving that message from one region to the next. Those neurons do not physically contact each other. Between the neurons is a gap, and that gap is referred to as a synapse. To bridge the gap, to move the message from one neuron to another, the neuron releases a chemical referred to as a neurotransmitter. That neurotransmitter diffuses into the gap, and then that neurotransmitter finds the next neuron and binds to a receptor on the cell membrane. There are many types of neurotransmitters and many types of receptors. We'll hit a couple of those. We'll talk about one right now. We'll hit a couple more in the next part, in the next narrated video. So migraine headache is believed to be, or one of the components of migraine headache is the effect of the neurotransmitter serotonin on a receptor referred to as 5-HT1B. And those receptors can be found on neurons, and those receptors can be found on blood vessels. So let's talk about the role of serotonin and the role of that receptor in migraine headache. We talked about headaches already, and we talked about headaches and elevated intracranial pressure. Remember, not all headaches are due to elevated intracranial pressure, but as a clinician, you certainly want to be able to pick out those signs and symptoms. What type of headache does this patient have? How has that headache been progressing? When are they experiencing that headache? And are you seeing other physical manifestations of elevated intracranial pressure? If so, that individual needs to be imaged to pick up on the mass lesion or what's causing the elevated intracranial pressure. Migraine headaches do not elevate intracranial pressure, okay? Migraine headaches do not elevate intracranial pressure. There are a number of different types of headaches. Headaches due to sinus inflammation, cluster headaches, tension headaches, and migraine headaches. Let's just talk about migraines for now. All that is a headache is not a migraine. I know a lot of people like to say, I got a headache, or I got the worst migraine, when in fact it might be due to sinus inflammation or a tension headache. That's not migraine. Typical migraine is unilateral, usually precipitated with a visual aura. The headache is described as throbbing in nature. The headache is associated with photosensitivity, tiredness and fatigue, nausea, vomiting, diaphoresis, and an inability to concentrate. And as you can see, there are a lot of different types of headaches, but it's this classification of a headache that makes you think classical or typical migraine headache. Migraines usually come on in teenage years, females more at risk than males. There is a familial incidence. There can be numbers of different precipitating factors such as stress, foods, environmental, exposure to chemicals, heat, dehydration. And it may take a while for an individual to figure out what's their trigger, or what is really leading to their migraine. Sometimes the migraine just occurs spontaneously. So most headaches, if you look at individuals with headaches, most headaches are benign and self-limited, such as the tension headache or a sinus inflammatory headache. You need to consider elevated intracranial pressure for anyone with a headache, so ask the right questions, characterize the headache. Is it getting worse? Is it associated with morning vomiting? Do you see cranial nerve abnormalities in their physical exam? If so, think elevated intracranial pressure. And if you have a true concern regarding intracranial pressure, then you do want to do medical imaging, right? You want to find that expanding mass lesion. Migraine now is not due to an expanding mass lesion. It's considered a primary dysfunction of the vasculature and of neurons. And migraine headache is, the pathophysiology is vasodilation and neuron hyperexcitability. And that vasodilation and that neuron hyperexcitability is due to the action of the migraine headache is due to vasodilation and neuron hyperexcitability. So one way that we can minimize neuron hypersensitivity and one way that we can minimize vasodilation is by taking advantage of the fact that serotonin on a 5-HT1B receptor inhibits neuron firing, and induces vasoconstriction. So back up, think about that for a second. Migraine headache, what's the pathophysiology? Vasodilation and neuron hyperexcitability. So what would we like to do to manage the migraine headache? Vasoconstrict and inhibit neuron excitability. How is that done? Through a neurotransmitter called serotonin on a 5-HT1B receptor. When serotonin hits that 5-HT1B receptor, the neuron calms, gets less hyperexcitable, and the vasculature in the brain constricts. Two useful mechanisms for ablating migraine headache. So commonly used drugs referred to as triptan drugs, they all end in triptan. The first on the market was sumatriptan, Imitrex. What those drugs do is they act like serotonin on a 5-1-HTB receptor. They're considered to be agonists, 5-HT1B agonist. By activating that serotonergic receptor, 5-HT1B, the neuron excitability diminishes, and the individual then experiences vasoconstriction. Important mechanisms for ablating the headache. An individual who does not respond to one may respond to another. So you may see headache specialists trying an individual on different triptan drugs, trying to find the one that they may respond to. Just because you don't respond to Imitrex after a couple of trials doesn't mean you won't respond to Max Salt or one of the other ones. And because these drugs induce vasoconstriction, you got to be careful. People with hypertension, coronary artery disease, past stroke, those would be relative or strong contraindications for using these drugs because, again, these drugs induce vasoconstriction. And then the last slide for part one, here's a new drug that just came out on the market within the last year. It's a monoclonal antibody. It's called Aimovig. There's two other ones that have been released in 2018. Aimovig was the first one released. It's a monoclonal antibody, and this monoclonal antibody binds another receptor in the brain. It binds a receptor called GCRP. That GCRP receptor plays a role in pain processing, and that GCRP receptor plays a role in neuron excitability and migraine headache. So now individuals who suffer from repeated and frequent migraine headaches may be eligible for receiving a once-a-month injection of this monoclonal antibody. That monoclonal antibody will bind to that receptor, that protein receptor, in the way all those other monoclonal antibodies we've talked about in this course that bind to proteins and protein receptors. This monoclonal antibody is specific for that GCRP receptor, and by binding it, inhibiting pain processing, the individual may experience less migraine headaches over the course of the month. And so far, it's been pretty favorable. Some of the, even though it's only been in clinical trials against placebo, it does seem to have some efficacy in lowering the incidence of monthly migraine headaches in individuals who suffer from recurrent migraines. My guess is it probably costs a pretty penny. I have no idea what the exact cost of this is, but a new monoclonal antibody with a specialty niche role like this is probably pretty expensive. All right, just something else to look out for. So again, some new pharmacology, and again, I like showing you some of that newer stuff that's coming out on the market. Dang, folks, 2 hours and 53 minutes, and that's just part one. So part two, hopefully, will go a little bit quicker. So now remember, what we got to do in this unit is we have to complete the 2 narrated PowerPoints. You've got 2 quizzes to take, a pathology quiz and a neuroanatomy quiz, and you can use all references for taking those quizzes. And I want you to respond now to 5 neuro threads. And remember, you also have an extra week to do this. So be sure you look at Blackboard and find out the exact due date and time for your 2 quizzes and the 5 discussion threads, but you do have extra time for that. And then Neuro Part 1 and Neuro Part 2 will be on that last Unit 4 exam, and there'll be 25 questions on Neuro Part 1. There will be 25 total Neuro questions on exam 4. Okay, you can tell my voice is gone. I'm shutting up at this point. I will see you in Part 2 of neurology. Thank you for hanging in on this.